Yes, ma'am.
Debbie Stolberg at the University of Chicago. I worry that one of our driving hypotheses is that we mainly have a PR problem. I think, John, your question suggested, we need to educate patients. Dr. Ernest, your point about the HMOs have a PR problem. And I would say it's not how do we convince patients it's the right thing, how do we make it that the experience is the right thing so that they want to come. I get and I believe deeply that advocacy and communication strategies are part of this. But I mean, just starting with the HMO issue, when my family members ask, I hear this buzzword of value-based care, and I hear that things should be coordinated, is that an HMO? I mean, what are we doing different nowadays that is not just let's redress up what we maybe thought was a good idea 30, 40 years ago, 35 years ago, but it didn't fly, it didn't sell. How are we actually making the patient experience better? Again, I get that advocacy is a big piece of that, and I'm 100% supportive, but I feel like we kind of need to start with the patient experience.
Right, so I can tell you for our HMO and our PPO, the patient satisfaction is the same, and they're asked directly, so we have surveys that are pretty robust to make sure of that. So we feel confident in terms of the patient satisfaction piece. But I think what's really different in the discussion now is, I think someone in the back talked about the patient and some of the transparency tools that really need to be available so that the patient plays a role in understanding. So I think historically, the gatekeeper model was like, the mother may I, can I, no, yes, no. And people didn't like that, and they responded to that. I think that, and they also weren't sure, quite frankly, where your incentives were aligned. And so I think when you think about what's different, the alignment of incentives is probably the most important piece of it. So really making sure that it's not just the dollars, but again, right place, right time. And so I'll give you an example of non-primary care, and that's with the Crohn's disease. So as a family practice physician, you may have a Crohn's disease patient that is, as they progress in the disease, really need to see their GI specialist more versus coming to you and then saying, write in referral, then you go to GI. There's a group of patients who really belong with specialists, and that's not just for GI, that's multiple diseases. So we took our intensive medical home model and we applied it to a GI practice here in town. And they have it's not a big population, but they have a population of Crohn's disease patients that they're in a value-based care model. So I think it requires a discussion, again, for all of us as physicians and as patients to be informed, and then as physicians and providers of care, not just physicians, and figuring out what's best. And I've seen it work so many times, that's why I'm repeating it, because it isn't anything magical. It's really what's best, and it varies. And Crohn's this model with Crohn's disease is a perfect example. We've all been there as family practice and had to refer to repeatedly for certain diseases when they progress, so.
If I may add to that, and this is something that I'm sure that you've heard, is the patient-centered medical home. And that is designed to enhance the patient experience. And part of the patient-centered medical home includes a patient survey. And I would wonder if the smaller practices would do just a patient survey. How are we doing today? What do you feel that you need from me as a practice? And I think that would provide you additional information in regards to servicing your patients. Additionally, with the patient-centered medical home, I'm not suggesting necessarily that you have to get NCQA or any organizational certification for your patient-centered medical home, but the tenets of having a patient-centered medical home are applicable to small and large practices. And moving towards that enhances that patient experience, theoretically and in reality. So I hope that is a...
Yeah, your question is well taken. What's different? Because there certainly have been reform efforts in the past about healthcare system. I would tag on to the medical home model. I mean, the principles for patient-centered medical home were only published in 2007, and our project is committed specifically to the continued evolution of that model and the patient-centered piece of it. It is part of what's different now is, the care you and I were trained to do initially was visit-based care, and now the connection between the patient in their medical home is an ongoing one. And to build on the survey, we're very committed to every practice, large and small, having some sort of patient feedback committee where you actually, the way to be patient-centered is to listen to what your patients want, because sometimes it's about parking or about your billing office, and it sometimes is about your care or your staff, but we have to be willing to listen if we're actually going to walk the talk of being patient-centered. I really appreciate the great questions. We actually are committed to taking a break. There is another Q&A session at the end, but if we don't stay on time, we will not let our other five. Okay, one more. I'm sorry, because she's standing up. We will let her go. All right. But she is cutting into your break, so quick question, quick answer.
I'll be really quick. My
There you
name
go.
is Monica Fudala from Northwestern. I just wanted to, we're talking about the value of primary care, and I just wanted to make sure that we're aware for people who are not in medicine, who know what family medicine is all about. I can tell you time and again, I'll have patients who come in and see me and they ask, are you an internist? What do you do? They don't even know that in family medicine, we do OB, we do pediatrics, we do geriatrics, we do women's health, adolescents. So we have a wide spectrum of care, and we're out there. And the other point I wanted to make also is, I think part of the problem is also, think about it from the patient's perspective. If you're having a healthcare issue, you may not know where you need to go. Do I go to the emergency room? Do I go to my primary care doctor? Do I go to the urgent care center? So I think part of our jobs as family physicians or internists, generalists, is to help guide the patient through the healthcare system so they know where they can go, and we can help minimize costs and improve quality of care.
Very good.
A great comment for closing this session. Being a Northwest guy, I lived until just 2 years ago my whole life in Washington State. I consider family physicians to be the wilderness guides for their patients, because the medical system is a wilderness, and you can get lost and you can get hurt, and so that is a big part of our role on behalf of our patients. So we're going to.
I tell you what I'll do while we're waiting for everybody to get seated. I'll tell you a story, because Monica mentioned that patients don't have any idea where to go, and that's where often where primary care physician comes in. And it kind of reminds me, did I mention I'm from Colorado? And in January, one morning in January, I woke up and my thigh was purple. It was kind of a disgusting purple. And, it didn't hurt or anything. I didn't know, so I thought maybe it would go away. And the next morning when I woke up, it was more purple, and my leg was purple. And my daughter saw this and said, God, Dad, you're in trouble here. Go get an MRI. Go to a hospital. Go to the ER right away. What are you going to go see a specialist? And I would. I was a little worried too. But I mean, what specialist treats a purple leg? A dermatologist, maybe? I had no idea. But the only doctor I know is Dr. Grady Holder, who's a member of the American College of Family Physicians in Denver. He's my doc. He knows me as a person, not just as an injured organ or something. And I went to see Dr. Holder, and he said, well, let me see it. And I showed him, and he said, okay, you're okay. What do you mean I'm okay? My thigh is purple. And he knows me. He says, well, you're a snowboarder, aren't you? Yeah, I am. And he said, and there was a big dump on Monday night up in the mountains, and I bet you went snowboarding on Tuesday. Yeah, I did. And I bet you fell. Yeah, I always fall. And he said, well, you broke a blood vessel. That's why your leg is purple. It's going to heal itself, and in a week it's going to look normal again. If it doesn't, come back and see me, he said. So, what if I'd gone to get an MRI or something? In Colorado, that's $1,400. A specialist would have been hundreds of dollars. That visit cost me $20, and my insurance company probably $50 or something. There you are, just exactly what Monica said. This is the role of primary care in our society. It is the junction between an ignorant patient like me and this very, very complicated healthcare system. So I thought that last session on new ways to provide care was really fascinating. And one of the things that kept coming up, although we didn't go into it in that last discussion, was, my team did this. Our group did this. And today, right now, we're going to take a look more at a team approach to providing health care. And as a matter of fact, when you look at these health care teams, it's a primary care doctor tends to be at the center of it. And that's what we're going to try to look at here. And so I'd like to ask each of our panelists to introduce yourself. Would you start, Dr. Albers?
Sure. My name's Janet Albers, and I'm the current president of the Illinois Academy of Family Physicians, and I'm also a fairly new chair of the Department of Family and Community Medicine at SIU in Springfield. And did you want us to say a little bit about the work we're doing now, too?
Yeah, tell us what you're doing.
Okay, well, one of the things in central and southern Illinois, there's a scarcity of mental health services, as you would imagine, in the more central areas. We have 4 residency programs there, Quincy, Carbondale, Decatur, and Springfield, who meet the mission of primary care, but we've looked at innovative ways in order to serve the behavioral health and mental health needs in that area. As you may or may not know, about 1 in 5 Americans have a diagnosable mental health condition in any given year, and about 50% over a lifetime. And about half of those manifest themselves by the time someone's 14. So kids are especially vulnerable, and 2 out of every 5 kids don't receive the mental health services they need. So in primary care at SIU, we've worked on integrating that within the medical home in some creative ways. And one of the ways down in Carbondale is a caravan that goes out to area high schools and provides services there, both medical health and mental health services. And then within the other, well, 2 of our programs are actually FQHCs, one's a rural health center. 2 of the other programs have actually integrated behavioral health consultants, LCSWs, LCPCs, within the medical home for just-in-time service, not away at a different place where you have to send your patient and there's stigma and they may not go, but right there within the medical home. So that's the work we're doing, and go on from there.
Mary?
Good morning. My name is Mary Dianza. I'm a registered dietitian, and I work with Loyola University Chicago, Marcella Newhouse School of Nursing. And I am a part of a program that has implemented a care coordination team within a primary care physician clinic. So we see patients from 2 family medicine clinics, and I'm part of a team with advanced practice nurses, RNs, myself the dietitian, social worker, also the physician. But we also include the service reps, all the medical assistants. Everybody who's in the clinic really has an important role in our team. So my specific role is to help patients learn how what they eat every single day can affect their health. So we do a lot of nutrition workshops, one-on-one appointments, sometimes team visits. We also communicate within each other, have monthly meetings with our physicians to discuss the patients. And also we do some population health work too, doing some community cooking classes and just really trying to promote healthy lifestyles every day to support what the doctors are doing.
Thank you. Dr. Edberg?
Hi, so I'm Deborah Edberg. I'm the program director for Northwestern's Family Medicine Residency Program in Humboldt Park. We are based at a federally qualified health center, Erie Family Health Center, on the west side of Chicago in Humboldt Park. And we are a teaching health center, which is a different type of residency program that has a different type of funding stream that guarantees training for primary care physicians. We know that by the year 2025 in the US, we'll have a shortage of about 52,000 family physicians, primary care physicians, and we don't have a great plan so far for how to fulfill that need. And so our program is one of about 60 in the country that will guarantee that the graduates will be family physicians or primary care physicians who primarily are going to take care of the underserved communities. And so our community health center is one of the best ways to train family physicians or primary care physicians who are going to go into that kind of work, because they learn how to do it while they're in training, and they learn what it means to work in a community health center, which utilizes team-based care like Janet was talking about and Mary was talking about. We've got nutritionists, we've got behavioral health specialists, we've got dental, optometry, we've got attorneys from Loyola that come and can help our patients who may be primarily focused on issues such as being evicted from their home. It's very hard to focus on your chronic diseases when you know that you may be homeless in a week or two. And so we address all of those disparities of health in order to help folks focus on their health care as well. And so we think that it's important to train physicians to learn how to do that in the best type of environment, and the way to do that is to train them in those community health centers.
Thanks. Dr. Jones.
Kohar Jones, Director of Community Health and Service Learning at University of Chicago Medicine, where I help to build the future community health workforce. I'm also a family physician at a federally qualified health center in the South Chicago neighborhood, the Chicago Family Health Center, where I work with health leads. Thinking about how to create the pipeline to train the future physicians in the skills needed to provide team-based community care, addressing the social determinants of health while promoting individual behavior change to address chronic disease.
And Dr. Lopez.
Good morning. My name is Carolyn Lopez. I'm a family physician, professor in the Department of Family Medicine at Rush Medical College, president of the Chicago Board of Health, a member of the State Board of Health. With respect to the Chicago Board of Health, a number of the things that we do include passing regulations that implement health-related ordinances passed by the City Council. But we do much more than that. As an advisory group, we're able to do things that the Department of Public Health can't do. So we've conducted community town halls where we've gotten feedback from the community about directions that the community believes we should take, and the most recent was specifically around smoking, and you'll hear more about that. In conjunction with that, we also had to do a press conference right before the vote on the ordinance, on the relevant ordinances, because our city council was Twitter bombed, and that press conference made a difference. It made a difference between the passage of those ordinances and not. Most recently, the board passed a resolution on the draconian cuts that were made to health services for the most vulnerable in our communities, and pointing out what is obvious to us, that not only the impact on the health of these folks, but the jobs would be lost. There would be a negative economic impact on this. It's yet to be seen what ultimate effect this will have, but at least we know that it got to the right committee and was read into the record in its entirety. So the opportunity for having an impact is there, and as a family physician, I've known and learned that family medicine, primary care, is at the junction of public health and population health. So I'm happy to be living the dream.
So, is the Board of Health, is that the outfit that grades restaurants and how clean they are?
It's one of the many functions that's conducted, and they do it in a variety of interesting ways because, of course, even though people will point out that the budget has increased, the demand for those services has increased at a much greater rate. So there are still inadequate resources for the workload. And the department has done a really incredible job of focusing in on strategies to utilize technology that will help target to the places in need, those facilities who need the attention, and made use of Twitter as a tool because it's well known that most foodborne illness is never reported to the health department. But people do talk about it. Okay? And now that we have Twitter, they tweet about it. And so there is an ability for the department now through an application to troll and look for tweets that relate Chicago, restaurants, and illness. And when they find that, they then proactively contact the individuals and invite them to file a report. And what they found was that it's really very interesting the difference that it makes, because in I'll call it an unsolicited report where somebody gets sick and decides to, or sees something, decides to call the department and file a complaint, the pattern there is something that's very visual, okay? Somebody saw a mouse, somebody saw an insect of some sort.
Yeah.
When the department does an inspection based on these Twitter feeds, what they find is something that's invisible to the public. It's the inadequate temperature that food's being held.
Yeah.
It's inadequate hand washing. It's things that very explicitly will cause disease. And it allows a very targeted intervention when and where it matters most.
So I think you can hear Carolyn is a family doctor who is also kind of the epitome of the concerned citizen and active in the community. And last night she was telling me it just really bugs her to see young people smoking when you consider what that's going to do to their health. So tell us about that, what you're trying to do about that, Carolyn.
Well, in 2011, a plan called the Chicago Healthy Chicago Plan was issued that laid out a map for improving the health of the people of Chicago. And among the many things that were part of that, which included, it's a very comprehensive plan, but tobacco and smoking cessation was targeted on by the board because when you look at chronic disease, okay, smoking is at the root cause, or certainly exacerbating cause, of a lot of it. Okay, so if we can attack smoking, if we can reduce smoking, we will have an enormous impact on chronic disease. So again, the town halls were conducted, and we were actually thinking more in terms of mentholated cigarettes, but what was clear from the discussions that we got in different parts of the city from very different communities was the same. It was help us protect our children from the smoking, and look at all smoking, not just mentholated cigarettes, not even just cigarettes, okay, but this new thing, e-cigarettes. And that led to the initiatives that the department had, where we had several ordinances, one of which brought the e-cigarettes under the jurisdiction of the Clean Indoor Air Act in the city. The other that was very significant allowed us to extend the distance from a school where cigarettes could be sold. Okay, so we had it for many years at 100 feet, and we extended it to 500 feet and included all cigarettes, flavored cigarettes, as well as mentholated in that. And that was a very important distinction because the FDA and their regulation applied rules to flavored cigarettes, but specifically and explicitly excluded mentholated cigarettes. And so we wrapped up the mentholated cigarettes with the flavored cigarettes and applied those restrictions to their sales. So we're not banning it, but we're restricting sales.
Is an e-cigarette dangerous itself, or are you worried because it leads people to smoke tobacco?
Yes. I mean, it's really both. The FDA, the CDC is starting to collect data on the uptake of e-cigarettes among our youth, and it's there. Youth smoking regular tobacco is down, but the uptake of the e-cigarettes is up. And so that's significant. The other thing that's known is that what we don't know about the e-cigarettes may be very damaging to us. There's data coming out all the time about concerns of what's in the vapor, because it's not just water. There's a lot of concerns and initial reports because of the concentrations of nicotine in the vials that were being used. and small children getting access to that and getting nicotine poisoning because of that access. So we have concerns around both things, about the actual health effects of the vapor and the fact that this is addicting our kids. And it's not something that we think is good for any of them.
Yeah, that's really, we don't know the long-term impact is what you're saying. So this is quite reminiscent. In 1953 in St. Louis, there was a family doctor named, he was a German, Ernst Winder, although when he came to America, he became Ernie Winder. But he was a family doctor, and this guy began to notice a correlation between his patients who smoked a lot and those who got lung cancer. This is 1953. And he went to the Surgeon General and said, take a look at this. I think there's a connection. And the tobacco industry said, oh, no, these are good for your health. And it wasn't until 1966 that the Surgeon General put a warning on cigarette packs. So you're right, I can see that. Now, we were talking about the team approach, and one of the really interesting things Janet's doing is you're putting behavioral medicine on your team. How does it work?
Well, it works a little differently at each of our sites, but basically there are therapists on site. So instead of referring somebody away to another site to see somebody where they may not adhere, they may not go, they may not feel welcome, we see them right at the time of care. So if I'm doing a visit and say I do a screening, because we're targeting kids up to 18, and there's a positive screen for social emotional issues, then what I can do is grab my member of the team and say, come on in, I'd like you to right now, while they're here, do some brief intervention, and then if needed, refer them for additional services. And in fact, we can even look at the schedule at the beginning of the day, do a huddle, where we look and say, these might be some people that would benefit by those services, and be proactive about it instead of waiting for them to ask for that.
So you're saying somebody comes in to see the doctor, the primary care doc, and if you say, I think you better go see a psychiatrist, they're kind of freaked out?
Right, they may be, but instead if we have a warm handoff and we have a therapist there in the office and we say, this is part of our team in the medical home, I'd like you to just spend a few minutes with this colleague who's going to talk with you, not just about mental health issues, but also behavioral health issues. So they can help with things like stopping smoking or weight management or stress management or different kinds of things as well. And it's really hard to treat medical illness, treat somebody's diabetes if they have depression or if they're having other issues. So addressing the whole person is key to outcomes.
And how many of the patients who come in need this behavioral health?
Well, I would say in any day, at least probably a lot of them. Actually, they say about 70% of all primary care visits have some component of psychosocial stress associated with it. But I would say in any half-day clinic, we probably at least 20, 30% have some intervention at that time. Perhaps there could be more. So.
And then they go off and get specific treatment with the...
They may, if it's a brief intervention that we can do then and then bring them back for a visit with the family physician and the team at a later time for maybe another brief intervention, that's fine. If there's more diagnostic evaluation needed, then we can refer them for additional services. And in this model that we've done with the embedded behavioral health consultants, the engagement with that kind of therapy has improved. They are fewer no-shows, they engage in therapy for longer, and they're better outcomes. So.
Do you have any data on outcomes of people getting healthier, if that's included in the care?
Well, better school attendance and better, anecdotally, at least better outcomes with their medical health. Again, better control of their diabetes. They're engaging more in our medical care because we've addressed those psychosocial issues as well.
We do this where I live too, and I think they're using the term integrated care. Is that used?
That's correct.
What does it mean?
Well, it just, again, means instead of referring somebody away to a different setting, it's all integrated and working together as a team, not co-located, which is quite different, No, we can be within under the same roof, but may refer somebody at a different time down the hall to somebody else. This is at the time of service. We're a team. We're working together. We're talking together, and we're working on these patients as a group, as a team.
So you mean somebody comes in with a bad cough or an earache or a rash, and you have the psychiatrist, psychologist there?
Well, I will say for the project we've done with Mosaic in Springfield, all kids, no matter what they're there for, get a PSC screening, which is a pediatric symptom checklist. So that helps us to know if they're having certain social emotional stressors. It's not just during their physical, but at any time we have access to them, because we may not see them again, right?
Yes.
So we take our opportunity, and it's interesting, we have, for those 11 to 18, pardon me, we have both the parent and the child fill something out. And there's sometimes some discordance between the two, and that can be quite interesting too. The parent may not recognize what's going on or vice versa.
Yeah, so are the parents resistant to this?
No, usually they welcome it.
Yeah.
Yeah, because it's accessible, it's embedded, it's integrated with the medical home, and it helps them. And for us, it really helps because a lot of those things can take more time in our practice as a family physician, and we're able to give better care in a more timely fashion, in a more efficient fashion, as we have those members of the team involved.
And how do the payers feel about this?
Well, we're again, 2 of the sites are federally qualified health centers.
Yeah.
One's a rural
Yeah.
health center. So we do get some behavioral health cost-based reimbursement for that. Some of the screens that we do, also there's a reimbursement code for those. And again, I think as we move toward value-based care, that's going to improve overall outcomes. So I think payers hopefully will continue to see the value.
Yeah, good, okay. And Dr. Edberg, you're doing this sort of thing, but in places where people don't have any money, is it?
Yeah, so, right. So like Janet, we work in a federally qualified health center, and this is where we're training our residents to work in that same team-based model. And just as Janet is saying, when you take care of folks who are vulnerable, who are underserved, who have lots of social stressors, it's not just about diagnosing somebody with diabetes and getting them their medication. It's about figuring out all the reasons that are contributing to their poor health. And so, I had somebody ask me once, how do you teach social determinants of health to your residents? And I say, well, they go and see a patient and they come and talk to me and they say, oh, he's got diabetes, he's not taking his medicine. And I say, well, why is that? I don't know. We'll go find out, because there's a multitude of reasons why someone isn't taking their medicine, right? They can't afford it. They couldn't get to the pharmacy. They couldn't take 3 buses with their 6 kids. Their electricity was turned off. They can't hold their insulin there, or like Janet's saying, they're depressed. Or you've got to figure out what those reasons are. And when you work in a community health center or a federally qualified health center, we can actually address a lot of those issues. We can, right under that roof, we can walk them down the hall, and as what Janet describes as what we call as a warm handoff. And our behaviorist is sitting right there, and we say, hey, this person is suffering from some mental illness. Can you help to address that while we're here today? They can make that connection and start to address that problem. And then I can help to figure out how are they going to take their medication. I can walk them. We have a nice relationship with attorneys from Loyola who come and offer free legal advice. So I can walk them upstairs to the attorney and say, hey, they're getting evicted or their electricity was turned off, and they qualify for services that they may not know that they qualify for. And a lot of my patients don't speak English, or they may not be documented, and so they're afraid to go into the system, and we're their only connection to figure out what they qualify for. I had a 40-year-old man who we had picked up from our inpatient service. He hadn't seen a physician in years and really just had a simple gallbladder issue. And when he came to see me, I was curious. He was there with his young daughter, which isn't as usual to see a man with his child. And I asked him a little bit about the impact of what his gallbladder surgery had done for him. Well, it turned out because of the pain, he'd been out of work for 4 months. And so I asked him, well, how are you doing on money? Well, not so great. And I said, how are you doing on food? I was watching his daughter doing her homework, and there's so much evidence about how you do in an educational environment if you're hungry. And it should be obvious, but obviously not very well. And so I was concerned about his daughter, and he said, and he looked really ashamed and said, not great. And so I was able to look up for him, there are food pantries in the area, and you qualify for them. It doesn't matter your documentation status. You've got a child who needs food. And I was able to link him with these services that are right in our community. And it just took, 2 extra minutes of kind of digging a little bit deeper. And that's what primary care is about, is figuring out what are the other issues that are going on and how do you really help this person. And then we can circle around and talk about all his other healthcare issues. So You know, I don't think there's a better way to train for that than for the residents to be right there and to see that happening.
So when somebody comes into your office, is it because they feel they have a medical illness, or is it because they can't pay the mortgage?
You know, they come in because of medical issues. You
Yeah.
know, a lot of people come in because their kids need shots, or because they're not feeling great, or some people come because they need a checkup. You know, women do that more often than men. A lot of them, because we're a residency and we have a relationship with our community hospital, we'll find them there because they've had an emergent issue. You know, I don't need to see you in my office in the middle of your heart attack, but when I find you in the hospital after your heart attack, I want you to come and see me so I can prevent that second heart attack. And a lot of these folks, they don't know that they have that option to have a primary care physician in a community health center that will take care of them regardless of their ability to pay. And that's what our mission is at Erie and at all federally qualified health centers is we are here to improve your health. You know, morally it's the right thing to do, but financially it makes the most sense anyway. It saves the entire system money, and we all pay for we pay for that. We pay for people who don't have health care, whether we believe in that or not. And so the best way to address that issue is to make sure that folks have primary care physicians.
It saves money partly because the alternative would be there eventually go to the emergency.
Exactly. It costs hundreds of thousands of dollars if you have a heart attack or if you have a stroke. Not just the healthcare costs, but the loss of work, the loss of income, the rehabilitation, and then the burden on society. If we can prevent that from happening, if we can address the chronic diseases, if we can address prevention, you save the system all of that, huge amounts of money, as well as improving the quality of life of the people that it impacts.
People come in who are pregnant?
Oh, yeah. So we take care of, sure. We take care of, people come in, they find out they're pregnant, that brings a lot of people into the healthcare system.
Yeah.
And, it's so critical, especially for folks with low resources, to get early prenatal care, to take care of the woman, and to take care of that infant, to start them on the road to health, to make sure that you, to try to prevent early births, which lead to, we heard on the panel earlier today about end of life. Beginning of life for folks who are born premature costs the system, close to that same amount of money. If we can prevent that type of expense, we can help kids get a better start on life, have a higher quality of life, be healthier.
How many people staff this FQHC?
Oh boy. So Erie has 13 sites.
I see.
I can't even.
Yeah.
We employ hundreds of folks in the communities that we serve because of our residency program. In part, Erie has been able to expand in the past few years out to various parts of Chicago and the outlying suburbs, to physician shortage areas to take care of folks in underserved communities. And really, we've been able to expand that just through the residency itself. We've been able to offer more than 13,000 patient visits a year. We've offered care to 3,000 patients a year, more than we were able to serve before just in our Humboldt Park site. So it's pretty impactful.
How many different medical specialties on the staff?
So our residency is family medicine, so it's primary care. Erie staffs nurse practitioners. We've got internists, obstetricians, pediatricians, all committed to caring for the underserved and really addressing outpatient primary care.
Yes, sir.
Could you touch on the importance of the FQHC model in training future family physicians?
Yeah, so we know there's been some data that shows that residents that train in federally qualified health centers or community health centers are 3 times more likely to stay in community health centers when they graduate. And so it's really pretty critical to give them that exposure while they're in their training to fulfill that workforce need.
Last night at dinner, I met Dr. Danza from Loyola University, and she said, "Oh, I'm not a doctor. I'm not a doctor." But you're on a medical team.
I am.
Mary, tell us about it.
Is this on? No, okay. I'm a registered dietitian, and my background was clinical nutrition, then community nutrition. Then I got this opportunity to join this this group of primary care physicians, along with the social worker, advanced practice nurse, and the whole team. And it's just been a really amazing experience for me personally. But we're also seeing that the patients are actually
getting a little healthier. So just like everybody says, we're able to recognize the barriers and address those at one time. I may ask a patient, who do you live with? How many mouths do you have to feed? Are you working? So on a fixed income, food is expensive. So we have to really teach these patients how they can make healthy foods for their families, or if they're gonna go out to the drive-thru, which many of the patients do for every meal, what are the healthier options there to choose? So really meeting the patient where they're at and seeing whatever we can do to help them. If they have an issue with transportation or money or anything, the social worker is right there. And, you know, the social worker has been very instrumental in helping me do my job to teach people how to eat healthier foods.
Do you get resistance? People say, I know what I want to eat.
Oh, yeah.
And what do you do?
Well, we use a lot of motivational interviewing. So we really ask, okay, well, what are your fears? How can we help you? You know, what's one simple thing, you know, in conversation, just trying to figure out what's one little thing that we can help with. I had a patient yesterday who was shaking. She was so nervous. She's like, I thought you were going to tell me I have to eat vegetables. I'm like, no, in my mind, I'm like, not at this visit, but maybe in the future. But, you know, she is willing to drink more water for the next 2 weeks. So we really have to really meet the patient where they're at, make them feel comfortable, give them the tools and resources that they need, and link them with the resources that are available in the community. And that's what, that has been helpful to the doctors, I think, who, you know, treat the patient, you know, holistically, but I can take the time to teach them how to cook or how to grocery shop or how to start a garden or some ways to really make the healthy choice the easy choice. So that's my role.
And do you see results? I mean,
Yeah, we just started this program in November, so we're still collecting data, but patients have lost weight. I think I mentioned I had a patient who cut his hemoglobin A1C in half. He wasn't taking all of his medication, and in a follow-up call from seeing, well, let me backtrack.
Yeah.
He came into the doctor's office. His blood sugars were mid-300s, so they said, get in here, talk to him and his sister. We found out he was boiling his meat in 7-Up, drinking Jello water, you know, just really high sugar diet, you know, really a couple things that are really happening that you wouldn't think are happening. So actually just 2 weeks ago, our nurse practitioner care coordinator called me aside. She's like, Mary, guess what? Your guy has cut his A1C in half. He is now cooking and bringing food to his friends in the community at the bar that he used to go to. So, I mean, it's really just, you know, giving people the tools to try and make the healthier choices and meeting them wherever they're ready to meet. We can't force people to do anything. You know what that's going to lead to, just resistance. So really just trying to teach people, you know, you can make healthy choices by doing cooking workshops. We have whole families who see our physicians actually come to our cooking workshops, and I always try and get the younger children to help actually make the meal.
Yeah.
So it really is impactful because the families trust these doctors, and it's just, the team I work with just really makes it kind of like a no-brainer that these people trust the physicians and the team.
what do you tell them about drinking?
Soda or alcohol?
We'll start with alcohol.
Everything in moderation. But, you know, one of our big pushes is trying to limit sugar-sweetened beverages, which we know is linked to chronic diseases. And there's a lot of advocacy out there right now, and really just trying to make people aware of their choices that they're making every day. We have sugar bottles, you know, with the different sodas that have 19 teaspoons of sugar, and you know, people's eyeballs get really big when they see that, and we can make that link to how what they're drinking is directly relating to the blood sugar that they're testing. So it's really just a lot of education and making it as easy to understand as possible and working with the patient and following up, touching base as often as they want us to. We don't push our services, of course, but just let them know that we're there to help them and support them.
So I'm starting to see some resistance to diet soda. Some people are worried about the sweetener. What do you think as a dietitian?
There's some that are on a list called generally recognized as safe, but there's really no firm guidelines that I'm aware of how much we can have. So we always just, usually recommend water. If you're going to drink juice, 100% juice, and low-fat dairy milk.
And does Illinois have a higher tax on sugared beverages?
Well, that is right now part of the advocacy. They're trying to push for a excise tax to tax the sugar-sweetened beverages at the counter so that people will see the higher price when they're making their choices as opposed to just the tax being added on at the cash register. So that is trying to be passed right now.
Mexico has a bigger problem with obesity than we do. And they just put in a tax on sugared pop and junk food. And their rule is that diet soda has to cost half as much as the sugared soda. And a bag of potato chips has to cost 4 times as much as an apple.
Wow.
Isn't that an interesting rule? And they do it with tax.
Yeah.
Tax can work, yeah. Thank you, Mary.
You're welcome.
And Dr. Jones, you've been working on social determinants of healthcare at a family health center.
I have, and thinking a lot also about how to train the next generation of physicians to be aware of the social determinants of health and to be able to effectively respond. As we're talking about the primary care transformation, the $2.9 trillion we spend on healthcare each year, 70% of that is going towards the diseases of lifestyle. And looking at how to shift the lifestyles of our patients, whether it's through the policies that change the e-cigarettes, whether it's through the teams that motivate for behavior change around diet and exercise. It's become critical for our future physicians to work on teams with an awareness of the larger environment in which the patients live, and to think about how to effectively partner with community organizations, agencies to advocate for the health of the patients. University of Chicago Medicine supports, through my position as Director of Community, or position as Director of Community Health and Service Learning, community health electives and service learning electives, providing space to teach medical students about social determinants of health, about motivating for behavior change, about how to work on teams, how to work on projects to shift health, whether that will be in their communities or in their clinics or with community organizations. And one program I run is the Summer Service Partnership Program, which is a really fascinating model started by Sarah Ann Schumann in 2009, and it's been running continuously each summer, partnering medical students with high school students from Chicago's South Side, adding now also an interprofessional team member, the social work students, college students, the tiered mentoring, where the students all together learn about the social determinants of health through lecture series, field trips, and also volunteer with community organizations, thinking critically about what's happening where they live, work, eat, and play that's shaping health. Who's the assets within a community that are working to promote healthier communities, to promote healthier individuals. And each team chooses a health topic. The high school students drive the choice of the health topic, and then the team together works on developing and implementing a health service project in the course of 8 weeks. Whether they choose obesity and the high school students teach middle school students nutrition, and
cool.
Create a community garden on school grounds. Also successfully advocating for a kitchen. You had talked about healthy choices being the easy choices.
Yeah.
At the charter school, there had been no kitchen. So the high school students would not eat lunch. It was frozen half to thawed ham and cheese sandwiches that they would just skip. And the high school students with the Summer Service Partnership team attended the Chicago Public School Board meeting, said, could we get a kitchen? And with the kitchen, they got fresh salads, fresh sandwiches, and began to shift some of the eating patterns.
Yeah, so I was going to ask you, what kind of topics do the high school students choose?
Obesity is popular. Violence has been very, sadly, prevalent
that's
in
a
the
public
minds
health
of the
issue,
students.
isn't it?
It's an
Yeah.
enormous public health issue, and it's very pertinent to the lives of the students. There's a 17-year difference in lifespans in different census tracts in Chicago. Zip codes, not DNA codes, driving the determinants of health. And one of the most negative aspects of gun violence is the hopelessness that it breeds and the sense of what can we do about this. There's this prevalent problem that foreshortens life, foreshortens possibilities. And building relationships on the teams and building the projects so that students can see small, meaningful changes can help to overcome that learned hopelessness of the teams. And it's wonderful to see what happens, whether one anti-violence project was to create a mural across from the beautiful Gary Comer Youth Center in the Greater Grand Crossing neighborhood. One of the students had lost her best friend during the summer program. And they created a peace mural of a dove flying out of the cage with the quote, "What you choose today changes all of your tomorrows." And that mural has been up there across from the from the cafeteria of the Gary Comer Youth Center for the past 3 summers, untouched by graffiti. Just really this visual testament to hope for the community. Wonderful to see, and wonderful to see that transformation, while also teaching them to advocate for themselves. We have op-ed writing workshops. A high school student published her op-ed on obesity and what we can do about it, the challenges that she faced as a young woman on the South Side with the dietary choices in the neighborhood, the safety exercise choices, but the commitment to change. And providing that pathway, providing skills training in advocacy, but most critically for our future community workforce in team leadership, team partnerships to come together to address the social determinants of health and to motivate for behavior change.
Would a traditional medical school curriculum include teaching on the social determinants of health?
Increasingly it is, and the big question now is how do we do this most effectively? How do we effectively teach about social determinants of health? And then how do we teach about the determinants of the determinants? So we know that the number one, we know that the number one killer worldwide isn't cancer or heart disease. It's cigarette smoking, now very closely followed by sedentary lifestyles.
Okay.
How do we teach about the life opportunities and exposures, what's happening in the community that's driving the health of our communities, while thinking about the unique role of the primary care physician as an interconnector, as a team member between the primary care centers, the clinics where primary care is delivered, and the community organizations that are addressing those underlying determinants of health, working with departments of public health, working to embed health in all policies, whether it's a 1 cent soda tax, 1 cent per ounce soda tax in Illinois, whether it's the diesel emissions laws nationally about how much particulate matter can be spewed into our environment, the pet coke on Chicago's South Side. Do we cover the pet coke piles and keep the air clean? The role of the physician within society, caring not only for the individual across from us in the examining room, but the populations who come to us in our clinic.
So this is getting huge.
It's huge.
Yeah.
It's a transformation.
And so there's clearly a connection or a juncture here between what you're teaching in medical school and public health measures.
There is. There is, and there will be partnerships, increasing partnerships. When we talk about population health, it will be not only clinical care, but it will be partnering with the organizations, with the societal forces that are shaping where health begins, where we live, work, eat, and play.
Yes, sir. Yes, ma'am. I'm sorry. Yeah.
Hi, I'm Marie Lindsay, and I'm a family nurse practitioner. Perhaps the only one in the room. But when we're talking about the shortage of primary care providers, I'm wondering, it seems the conventional wisdom is that, thank you, medical students are, you know, they have big debt, and that they want to go where the money is. But I wonder if there's another issue that doesn't get enough publicity. Namely, it's a lot of work to be a primary care provider. You have to know a lot of things about a lot of things. And it's attractive to go into a specialty where you can really narrow your focus of your energy and your learning. And I wonder, in all of these programs, we have so many people representing primary care physician programs. Is that discussed in medical school, I guess, before they make their decision to be for a residency?
So, I would say that we talk a lot about the hidden curriculum in medical schools, which is often anti-primary care in a lot of reasons, and that is one of them. Often, it's funny to me that a lot of students will hear, oh, you're too smart to go into primary care. On the other hand, oh, you're not smart enough. You have to know too much to go into primary care. And where is the truth? I went to a very primary care strong university when I went to medical school, and I never really heard from anyone that I was too smart to go into primary care, which maybe more is a testament of me than university. I don't know. However I want to take that. I think that it's possible that students might feel overwhelmed that, yes, there's a large amount you need to know, and there's an awful lot of work that you need to do. There are two responses to that. One is that the amount of work is addressed in a team, which is what all of us are talking about here. It's no longer the sole responsibility of the physician to address all those needs that a patient has, especially when you're taking care of an underserved population. There are an awful lot of needs, and if I was sitting there in an office by myself and a patient came in with all the things that my patient needs, I would feel very overwhelmed and I'd be burned out and probably would have quit a long time ago. But I can turn to my partners who work in my health center and say, hey, Mary, this patient needs to talk about nutrition, and Janet, can we get the behaviorist to come in and address some of the depression? And I don't have to do that. It takes me 2 seconds to say, oh, here's what you need. They're right down the hall. Let's have them take care of that. And as far as what you need to know, for me, I think that that's the fascinating challenge of primary care, and I think that our medical students are bright enough to handle that. And the ideal way to train is to teach them how to learn. Here's your scope. It's pretty broad. It's going to keep you interested for a long period of time. The learning curve doesn't stop at the end of medical school or the end of residency. You're always learning. And then here's the point where you partner with your subspecialists. And our federally qualified health center is fortunate that we have a great partner in Northwestern who has an agreement to take care of our patients even without coverage when they need it. But we work closely with them and we train our residents to know what we can do up to a certain point, and then when do we have them work with the specialists. And I think that that's what keeps it interesting. I think the most important the best part of primary care is that you've got a relationship with your patient and you really get to know them and to know what's going on in their life, and you have that medical piece that keeps you interested and keeps you engaged. And this is the era of technology. If I don't know something, I pull out my phone and I probably know it in 2 seconds. You can Google whatever you want to Google, and so it's not challenging in that sense. And so I think that for medical students to get to see that, if they have appropriate mentors in primary care that show them what it means to have a sustainable career, that fear, if it's there at all, goes away because they see what it's really like.
Well, is lower pay a factor?
Certainly. We're doctors. None of us are impoverished. I take care of the poor, so I think that I personally believe that it's more the differential. We live in a society where we pay for what we value, and if you're a medical student and you see a subspecialist, getting paid 6 times what a primary care physician is getting paid, you think that that's where the respect is. And it's not so much about the dollars. I mean, certainly debt is an enormous burden for a lot of people, and that's absolutely can't be ignored. But it's also the difference in value that we're teaching students what we value in this society, and we tell them that we value subspecialists more than primary care, and that's just not appropriate.
You know,
if I could just add to that, one of the things that I tell students is, it's a common joke, internists know everything about nothing and family practitioners know nothing about everything. And I think the thing that people don't realize getting into the primary health is primary is just people don't realize, like I went to Lutheran General and we saw more pediatric patients in family medicine than the pediatric residency that had more residents. We saw more internal medicine patients in our family medicine clinic than the internists, because even in their senior year, they did 2 afternoons, and we were there every afternoon. And so I think, one of the things is we become the specialists at outpatient medicine is one thing. And just to echo the other thing, and I hope I'm saying this for the right reason, I was fortunate to be the outstanding graduate of my medical school class. And I almost did not, at UIC, I almost did not go into primary care because I was told by all these specialists I am throwing away my potential. Like you could be anything, right? And fortunately, because of mentors, I stood the course and it was the best decision I ever made. So thank you.
I'd like to really quickly speak to the idea of comprehensivists versus partialists, and that the primary care physicians are the comprehensivists who care comprehensively for patients and communities, rather than the partialists who just take a small piece. And many of us have seen a graph of pediatrics knowing everything about kids, internal medicine needing to know everything about adults, and yet most disease is experienced by a community. Most of what a community experiences, 90% of the complaints are 10% of the disease processes. So you end up needing to know fewer disease processes really well across the entire age spectrum in order to care comprehensively for a community.
Yes, sir. Yeah.
I really appreciate the question that the nurse practitioner asked. But the other side, again, and I apologize for asking about economics again, but Deborah, with your program and residency, are there any specific things that you guys are doing, or Chicago or the state of Illinois, because I have a daughter who's a second-year family practice resident, to actually help them move on economically past their debt and everything else, and to encourage them and to practically and reasonably afford to go into primary care to serve the underprivileged people that they really want to serve? Is there anything specific that's being done to enable that?
I mean, there's National Health Service programs, there are state-based programs that will do loan repayment if you agree to work in underserved areas, and a great proportion of our community health center physicians get their start there. And it's an amazing program because the majority of them end up staying in those areas as well. And so that's probably one of the biggest relievers of debt, is to look into those programs. I had most of my loans paid off by a state-based program, which I'm not sure still exists, to be honest, but National Health Service still does, which is a federal program, which helps. I think beyond that, like I said, it's a very real issue. But I would also tell your daughter she's got to follow her passion. I mean, she doesn't want to be in a career that she doesn't feel fulfilled. The money is important, but it will also come, and it will be less important if she's doing something that she really feels has value, which is what this is.
Well, I appreciate that. So the question so much isn't for my daughter's concern, but as a resident and a physician in the Chicago area and in Illinois, there's not reimbursement. There's not doctors that are going and being part of the Medicaid program for kids and things like that, because it's not there. So is there things that are going to really happen and change? Does anybody know that to make that shift? Because without that, then there's none of us are going to be practicing. At my hospital, I initiated a program for family doctors to take on no-doc newborns, because they didn't have any doctors. They weren't being seen and staying in our system. So we started doing this, but yet every patient we couldn't see in our office because we weren't part of the Medicaid program. Our hospital just wasn't getting us connected to that.
Yeah.
So that's a real practical issue that maybe the two of you that are practicing the way you are in the city have some answers down the pipeline.
Yeah, I mean, I think it's, it's advocacy. All of our organizations do quite a bit of advocacy work around just that, because we know that is an enormous issue, and our organizations know that's an enormous issue. And so there's a lot of advocacy, and I think that's where it needs to happen. Cara was talking about the social determinants of health. We went to a conference recently where they started talking about the political determinants of health. And I think that's probably where that movement needs to head.
Yeah.
Yes.
You all have the voice and you all have the stories as the practicing physicians of why it's important and what needs to happen. And having your daughter share her story about what she wants to do and what the tensions are for and minus helps to shape the legislation. We're part of the system, that we can help to shape the system we live in.
Yes, sir. Yes, ma'am. In the middle.
I'm Christina Dacus. I just graduated from University of Illinois at Chicago. And I just wanted to give a little bit more of the student perspective, just to echo a lot of what's already being said. Like, we were fortunate at UIC because I think about 10% of people in each class go into family medicine, but still there are more people going into emergency medicine than family medicine, which I think is a problem. I was talking to a student yesterday, and she's almost done with her M3 clerkships, and she hasn't been on a clerkship with a single person who also wants to do primary care, which is a real problem. I know there's a lot of schools in Chicago that don't have family medicine clerkships at all. So my question is, we've already kind of addressed this, but what are concrete ways that we can get students more excited about family medicine, especially in the face of all this debt? Like, what needs to be done so more people are going into their clerkships thinking, oh wow, primary care is awesome? Because I don't see that.
Yeah.
Well, I'm going to actually take that up, the little Dr. Public Health here. But this is actually, if you really want to excite people, and I would even suggest to you, if you have not done it, okay, the Academy of Family Physicians annually has a meeting. It's now just gotten to be the national conference, because everybody knows, okay? It's the National Conference of Family Medicine Residents and Students. And if you don't walk away from that energized and believing, then you did not attend the conference.
Yeah.
And there are a lot of schools that are making a strong initiative to make sure that they get people there. Okay? The State Academy has had initiatives to help fund it. Okay? Nationally, there's, I think, some money still available to help fund students to get to that, because it's actually that important and that significant. The other thing is the family medicine interest groups within your schools. Okay, now some schools are very activist about it. That would be my preference, because it's hard for students sometimes to get themselves organized. Other schools take a more passive approach and just kind of let it be, and let the energy percolate up from the students. And I guess that's an okay approach. It's just not, I'm more of an activist type in that regard. But look and try to help within your school organize around those interest groups, and then get connected with the Illinois Academy, okay, because they will help connect to all these other programs.
Also thinking about the meaning in medicine, so linking the primary care with the social mission of medicine. What brings people to medical school, many who are interested in primary care, is the desire to care for others in meaningful ways, and identifying the training opportunities, and asking if your school doesn't provide the training opportunities to create them. To remain connected, whether it's following along with home care providers to see that the relational value and the economic value of primary care.
You know, I mentioned that 64% of the doctors in Great Britain are primary care docs. So how do you do that? Well, for one thing, the health minister constantly says that the whole system is built around primary care docs. It's a constant refrain. Traditionally in Britain, and you can see this in these British TV shows in America, the surgeons and the specialists who work in the hospital are known as Mr., and the family doctor on the high street is called Doctor. That's traditionally true in Britain. And then I asked, you know, this woman who came to our house to treat my daughter, I asked her once how come 64% of the docs are primary care doctors. She makes twice as much as a cardiac surgeon. That'll do it. And it makes sense. Yes, ma'am.
Hi, my name is Elise Rupert, and I represent
Yeah, you're on.
Community Health, which is the largest free clinic in the country. And all of you represent amazing organizations and programming that is, you know, kind of nipping this primary health care issue at the bud, you know, having great patient outcomes and ultimately impacting expenses on the opposite end. But there's a huge population of people who aren't eligible and don't qualify for any of these services. And so I'm just curious to know, was there a particular reason that the free clinic sector was left out of today's conversation?
I'll speak on behalf of the project. I mean, it's hard when you have so many good stories to get them all represented in a panel of only 8. And, you know, our initiative is multiple cities. The other thing we really don't have up here today is about direct primary care practices, which is sort of a new innovation in primary care that was highlighted at our Seattle city tour event. So it's certainly not a purposeful exclusion, but a good point that has just been heard by somebody sort of in charge of that. So.
Yes, sir.
Hi, my name is Mustafa Alavi. I also just graduated from UIC, and I'm going to family medicine. I had more so a quick comment about our loans. So I'm coming out with loans of around $289,000, which is a really scary number, but I knew early on I wanted to do primary care, and I had mentors in family medicine who told me they weren't afraid of paying off the loan burden. I'm also not afraid of paying it off. I'll still be making the top 5%, and I think we need to convey that to medical students that we'll be able to, no matter, regardless of specialty, you'll be able to pay off that loan amount. It might take a little longer, but it's doable, and I'm doing ultimately what specialty I know I want to do. So if we make sure as future family physicians, or as family physicians, that we address our students' needs and let them know that I'm living comfortably, I'm doing what I want, and I'm happy. And I think we could get more students interested in going into family medicine that way. And Dr. Haidari has some stats about it.
Nice handoff, right? Trained you well, Mustafa. So, my name is Abbas Haidari. I'm the curriculum dean at University of Illinois at Chicago, and actually it's more than 10%, Christina. In fact, we had about 23 students out of a class of about 180 graduates going into family medicine, and so I'm exceedingly proud of that in an urban setting where Northwestern has a class size of about 180, typically have less than 5 students going into family medicine. And the literature has some key reasons that has studied this. So we actually have literature to support what leads to this. So number one, does the university have a Department of Family Medicine? Yes or no, right? Let's go down the algorithm. Does the university have a family medicine clerkship? Yes or no? Does the family medicine clerkship have a certain length for amount of exposure? 4 weeks, 6 weeks, 8 weeks, you can see where I'm going. Does it have good mentorship and role modeling? Does it actually have community-based experiences where there's actually value added and the role of the student is actually valued as part of a team? Yes or no? If we can answer yes to those questions systematically and universally across our medical school education system, we will graduate more family physicians. For sure, the literature supports it. The other thing you mentioned about the percentages in England, we don't have to go that far. I have a colleague at McGill University who's in the curricular dean's office. And they actually, as the country of Canada, have set a national metric of 40% graduates is what they needed, because they did some modeling and they partnered with their economists and said, these are the number of family physicians that we need as a society. 40% was the number. So every school, including McGill and its kind of quote-unquote Ivy League echelon, is making that commitment. So I think we need the economic and political will for legislators and policymakers to say, what are the needs of our society that would then drive the needs of our educational system? The other way around would not work.
Yeah.
Director of Family and Community Medicine at Northwestern. Bus, it wasn't quite that dismal. It was 6 of 160, but we're working on that. So, but we do value family medicine extraordinarily at Northwestern. I wanted to bring us back a little bit to advocacy, and congratulations on the amazing work all of you are doing. It still comes down to dollars. And so we know, Deb, the program in family medicine, it's a phenomenal program. 3 times more family physicians going in to serve vulnerable communities than what they would. But what's happening to the funding? And so I think we need to talk about that.
Okay, thank you. Glenn.
Well, we're running out of time, although I know we're not running out of questions. So I appreciate your, I was going to try to cut off even before Deb, but I know better than that. So I was not going to do that. So first, before I make some closing comments, if you would join me in thanking our panelists and TR Reid. I think we've heard some amazing stories, and I would just like to highlight some of the comments we had. I appreciated the one about preceptor experience, and I hadn't mentioned it to this point. We talked a lot about the triple aim, but the Family Medicine for America's Health is very much focused also on the quadruple aim, and that fourth piece is professional satisfaction and a sustainable lifestyle. And we as family physicians often are our worst enemies at trying to create student interest when we are giving them a sort of a burned out family doctor appearance. So we need to change the system so that we are reflecting the joy that we feel in here, but doesn't always show out here. So I'd like to thank all of our panelists. Dr. Ernest, I appreciate the comments about changing the payment system to really align with the incentives we want. We have a fee-for-service system that pays you to do stuff regardless of whether it actually helps people. And that's, you get the incentive, you get the behavior you incent. So we need a system and a path to get there. I think that's just really really important. I like the comment about the edifice complex. I don't know if that gentleman is still here. My similar comment is weapons of mass construction. But you know, people say, gee, how can you have been happy in a 30-year career in family medicine? You know, the primary care hasn't gotten the stature it deserves, and yet right now I would not want to be the CEO or CFO of a hospital or a large health system. Their world is about to change in a tectonic way, and I don't know that they're prepared to face that. So if you ask me which hat I'd rather right now, I'd rather be the family doctor. Dr. Cornwell's great stories about home visits and actually having a patient-centered healthcare system where you actually reach out to patients where they are and what they need, and how much that can really help us achieve that triple aim and that team-based aspect where it isn't always the doctor that has to go out there. It may be the social worker or the dietitian or the pharmacist, that whole team-based aspect, which we heard many times. And this teaser of how technology is going to help us. You know, it may be the doctor that needs to be the contact, but maybe they don't physically have to be there. They build that relationship, and follow-up visits can be, you know, virtual or electronic. So stay tuned for that. That's a particular area of focus for our Family Medicine for America's Health initiative. Dr. Argain's comments about hospice and how we really need to listen to our patients to get their goals for their care, and that is best obtained in a continuity trust relationship between patient and doctor. She was sharing how often referrals come so late in the course when it can't help people as much as it could, because people don't want to face the concept. We see it all the time as family physicians. You refer somebody to hospice, and that means I've got less than 6 months to live, and I don't want to hear that. Well, you may hear it more from somebody you've known for a while that you know cares about you and is not giving up, because that's not what hospice is. It's taking their care to another level. And very much hospice, a great example, not just of team-based care, which it is, but of family-based care. Supporting caregivers and families beyond the time their loved one dies is just as important as during their care. Dr. Lopez's comments about public health, and we had several comments about health of populations and integration of public health. If there's any more under-recognized and undervalued pieces of our healthcare system, it's public health and behavioral and mental health. And yet, if we are going to achieve a healthier population, those are absolutely integral, and we've heard great stories about how those are incorporated not just under the same roof, but in the same practice in a coordinated and integrated way to improve health. And this this aspect of social determinants of health. You know, we as physicians are as susceptible as anybody else with the fascination of our healthcare system, you know, genomics and imaging and implantable devices. But it's getting that person that food voucher because they were in for a medical visit but couldn't feed their child. There isn't any medicine that takes the place of that. You have to practice in the community, and hence the title, Family and Community Medicine, which I am glad to see us in our medical schools embracing more and more. Appreciated Dr. Albert's comments about the behavioral health piece that I spoke about and how common it is that people have both behavioral and mental health issues and physical illness. And if you treat one or the other, you are not going to be successful, either in improving the health of that person or in saving the healthcare system any dollars. Dr. Edberg's comment about teaching health centers and their dual mission, which is to provide care for the underserved, but the teaching health center mission of training folks who then are going to be familiar with and comfortable practicing in that environment, and that statistic of 3 times as likely to practice in a community health center if they train there is an important one. But to the advocacy point, it's a program that currently has a finite period of funding and an area where we all need to stand up and say that's something that needs to continue. I want to thank our only non-physician today, Ms. Danza, representing our colleagues that are part of that team. And dietitians do an incredible contribution to the team model of care, along with nurse practitioners and physician's assistants and pharmacists and diabetic educators and physical therapists. Everyone has their focused area of expertise and training that they can bring to bear on the best care. And it gets away from, as she was saying, that idea that it's all got to be in my head and under my control as the physician. It doesn't. I can rely on my team members. And not only does my patient get better care, but I probably learn something along the way, which is one of the things I enjoy about being a physician. And Dr. Jones's comments absolutely on point about social determinants of health. As I said, if we focus only on that 10% that healthcare itself contributes to people's health, we will fail, and we will fail miserably. So those aspects of patient safety, about behavioral issues like drugs and alcohol and diet and fitness and wearing bike helmets and your seat belts and all that basic stuff, we have to be part of that system. And that is the system that Family Medicine for America's Health is advocating for, to make health primary. So in closing, I would just I point you to the 2 websites for our initiative. FMAhealth.org is the campaign website for the strategic effort. If you're a family physician or other allied health professional and interested in contributing to this effort, there's an email drop box, info@fmahealth.org, where you could express your interest or just follow along with our effort. And then the Health is Primary has its website, healthisprimary.org, which has information about this communication effort, downloadable things like the posters you've seen outside and things. You can put them up in your office or your clinic or wherever and help us get the message out there. There are also resources for patients about how they can take up an active role in the care of themselves and their families and improving the health in their community. So all of those I hope you will rely on as resources. So once again, thank you for being here. Thank you for the interest in this, and thank you for the efforts that all of you make to make health primary. Thank you.